Hi, my name is George Berdejo, and I am the Director of Vascular Ultrasound Services at Montefiore Medical Center in New York City. Today I'll be going over with you techniques and protocols for the use of duplex ultrasound in the evaluation of the carotid arteries. Most of what I'll be talking about today has been extracted from the SVU procedure protocols and guidelines, which are available at www.svunet.org. Today I'd like to go over the use of a cerebrovascular duplex ultrasound for evaluation of the carotid arteries and go over some basic protocols on how to do it well. In the evaluation of any patient, I believe that it's important to do a little bit of a patient history and some preparation involving both the patient and the technologist. It's always a good idea to explain the procedure to the patient. It puts the patient at ease. We typically like to, what we say in our facility is to under-promise and over-deliver. So we always give the patient the general idea about how long the examination will take. Again, it puts the patient at ease and relieves some of the anxiety associated with any diagnostic testing. We believe it's always important to obtain a history and a physical examination, at least a limited physical examination in your patient. And we always do an assessment for risk factors. We ask questions regarding previous surgeries. Of course, the primary questions would be questions regarding any previous carotid endarterectomy or perhaps carotid stenting. In these patients, of course, the examination would be modified to evaluate those issues. It's always important to elicit a history for symptoms as well as the reason for the referral. For instance, if a patient comes in with a chief complaint of transient loss of vision in the right eye and some transient loss of function in the left side of the body, we would more judiciously evaluate the carotid system on the right, of course, because that would be the vessel referable to those symptoms. It's always a good idea to look at the results of any other previous tests that may have been performed in your patient, and that would include any CTAs, any MRAs, or perhaps any carotid duplex scans from another facility. And we always look to do a review of any previous studies that have been done in our own facility, and that's important because you want to be able to reproduce the whole situation from the previous examination. That would include using the same Doppler angle, the same beam angle, and if possible, if you have more than one piece of equipment in your laboratory, to use the same piece of equipment on a follow-up study. We may or may not perform a brachial artery blood pressure. We do not happen to do that routinely. I know there are some laboratories that do that. We have an algorithm in place that calls for the performance of a bilateral brachial artery blood pressure. And of course, any patient who presents with symptoms referable to the posterior circulation, or any patient, of course, that's referred for asymmetric bilateral blood pressures would get an evaluation in our lab and also get an evaluation of the bilateral subclavian arteries as well. These are just some of the common indications for examination of the carotid arteries, and they include any patient who presents with transient ischemic attacks, any patient who has had an episode of amaurosis fugax. Carotid bruit is probably the most common indication in our facility. Any patient with a history of stroke. We would follow up an examination in any patient with a known stenosis in excess of 50%, and we do that about every 6 months or so. It's appropriate to follow these patients up after an intervention, the most common ones being carotid endarterectomy and carotid stenting. We get a few referrals to evaluate the carotids and the vertebral arteries in patients with asymmetric blood pressures. And of course, it's always appropriate to evaluate the carotid arteries in any patient with trauma referable to the area of the carotid artery. In terms of equipment, any standard duplex scanner can do the job. Color flow is not absolutely necessary, although color flow is probably available on most of the machines that are out there today. It does help in identifying vessels, and it serves as a very good guide for the placement of the sample volume when evaluating patients with stenosis. And therefore, it does reduce the overall examination time. However, I have not yet seen any papers that have shown that the addition of color has improved the overall accuracy. You could probably do just as good a scan in terms of accuracy with or without color, although color does absolutely serve to help. In terms of equipment and instrument setups, we typically like to use the highest frequency that allows us to see the vessel of interest, but anything between the range of 5 and 10 will do the job and do it well. In terms of image orientation, we typically orient the image so that the head or the brain is to the left of the monitor and the heart is to the right of the monitor. Now, as you know, in terms of color flow assignment, any flow, color will be set so that flow toward the transducer can be either red or blue. In our facility, and I think by convention in most vascular laboratories, we typically assign red for arteries and blue for veins just for consistency. In terms of the color box or the ROI box, ROI, which would be region of interest, keep in mind that the wider the box, the slower the frame rate. So we try to keep the box as small as possible, especially when we're evaluating suspected stenosis. And also keep in mind that the color scale and the color gain really should be adjusted throughout the examination to evaluate changing velocity flow patterns, as well as to compensate for the differing depths of all the vessels that are being evaluated during the examination. So it's important for the technologist to make all those adjustments as he or she is moving on throughout the examination. A complete examination is a bilateral examination that includes evaluation and visualization of the common carotid artery, the carotid bifurcation, the internal and external carotid arteries, as well as the vertebral artery, and again, sometimes the subclavian. We do not routinely look at the subclavian artery in our laboratory. However, if there's some specific indication to look at the subclavian artery, we will do that. Now, most of the examination really concentrates on the area of the carotid bifurcation as seen here and the origin of the internal carotid artery. However, it is important to evaluate the remainder of the extracranial carotid arteries as well, keeping in mind that indirect findings will sometimes point you to the area of interest. In terms of recording sites, for a normal study, we typically would acquire 12 images, at least 12 images, in what we like to refer to as predetermined sites. And now keep in mind, we're looking at the entirety of the extracranial carotid artery system during the examination, but those images that are acquired would include the mid-common carotid artery, somewhere 2 to 3 centimeters proximal to the carotid bifurcation, the bifurcation itself, and at least 2 measurements within the internal, somewhere in the proximal portion of the internal, and then further out distally. We would then acquire an image at the origin of the external carotid artery and one at the vertebral, and again, sometimes within the subclavian. Again, every study is bilateral, so we're talking about at least 12 images per study. And also keep in mind that the number of images acquired will vary according to the specific laboratory protocols, which gives me an opportunity now to mention that every laboratory should have a written protocol in place. And this is important because it promotes consistency from one study occasion to the next. And also it's very important in labs who have more than one technologist on staff. We need to know that we're doing the same thing from patient to patient. That's very important. So it's important to have a written protocol in place. Now, most of the examination will happen in the long axis with the transducer sagittal to the long axis of the image, keeping in mind that you'll use multiple approaches for evaluating the carotid arteries. Probably the best approach for evaluating the internal carotid artery would be the posterior lateral approach. Another very important thing is to keep in mind is that when you're evaluating for plaque content, we typically do that in the long axis. For instance, in this patient here, we can see here in this long axis image of the common carotid artery near the origin of the internal, and including the bifurcation, that there's some wall thickening seen here in the far wall and on the near wall. Here's a little bit of a moderate plaque at the origin of the internal carotid artery, and we will probably classify this as a mild to moderate homogeneous plaque at the origin of the ICA. And we really use only 4 or 5 words to evaluate plaques. And those would be homogeneous or heterogeneous to talk about the content of the plaque. Could either be echogenic or very echolucent. And when we talk about the surface or the border of the plaque, we talk about the plaque being either very smooth or it can be irregular. Another thing to keep in mind is in the acquisition of your flow velocities, that really should happen only in the long axis. I think it's okay to drop a sample volume within a vessel in transverse only to identify that vessel in terms of whether or not it's the internal or the external carotid artery. But the acquisition of a blood flow velocity really should be obtained only when you're sagittal to the long axis of the vessel. It's the only way really to know that you're parallel to the vessel walls in terms of your sample volume. And the two measurements that we're interested in, of course, are the peak systolic velocity and the end diastolic velocity. Now in this image here, another long axis image of the carotid arteries, you can see here the carotid bifurcation. This is the origin of the internal carotid artery. We can see here that we have a relatively heterogeneous plaque with very irregular borders here, and this is probably a more dangerous plaque than the one that we noted previously. Here's an example of an acquisition of a blood flow velocity. Again, we see here a long axis image. You can see the carotid bifurcation to the left of the image. Here, the internal carotid artery. You can see a color flow jet. The sample volume has been placed appropriately. The Doppler cursor is positioned so that it's parallel to the vessel wall. We have a 60-degree angle and a resultant velocity that's in excess of about 350 centimeters per second. And this would be the appropriate setup for evaluating the origin of this internal carotid artery. Now, in terms of blood flow velocities, in a normal vessel, the sample volume really should be in the center of the artery with the Doppler angle cursor parallel to the vessel wall. Now in our facility, we always make sure to angle correct to 60 degrees, and this is particularly important, especially at the origin of the internal carotid artery, as well as in the common carotid artery, especially if you're using an internal carotid to common carotid artery ratio for the evaluation and estimation of carotid stenosis ranges. It's almost always possible to obtain 60 degrees. Of course, you never want to use more than 60 degrees. In any case where you're using less than 60-degree angle, I believe that it's appropriate to document which angle that you're using. And again, this is particularly important in follow-up studies. If you're using anything less than 60, when you're doing a follow-up for comparison, you really want to make sure to use the same angle during that follow-up study. In terms of the sample volume gate, which is the width of the gate, you want to be about 1/3 to 1/2 of the vessel diameter. Keep in mind that the larger the size of the gate, the more likely that the signal will be detected. However, there is a trade-off in terms of eliciting increased noise within that sample. So I think it's appropriate to open up that sample volume wide when you're searching for the highest velocity within the stenosis, but I think once you find it, you can probably decrease it a little bit to decrease the amount of background noise within that spectral waveform. Another very important factor is to make sure in the presence of suspected stenosis that you're obtaining at least 2 to 3 spectral analyses per suspected stenosis, all of which put the patient within the same stenosis range. 1 or 2 really is not enough, especially if there's some contradiction about which range of stenosis that patient is in. So you want to get at least 3 spectral waveforms per stenosis. I just wanted to share this image with you today to show you that sometimes even placement of the cursors for evaluation of the velocities can sometimes be an issue. Here we see the cursor set or the caliper set so that it's at the peak of systole, and this is where you want to measure that, always at the peak. If you can run an EKG while you're doing the examination, that's ideal. You sometimes don't have the capability to do that, but here is the peak, and end diastole should be measured somewhere in this range. By definition, really, it's defined as 100 milliseconds before the start of the next systolic upstroke, and we don't expect our technologists to measure that. However, we do think it's appropriate to be somewhere in this area. Diastole should not be measured here or here or here. It should be right here at the end of diastole. Another very important feature in terms of evaluating patients with suspected stenosis is to be able to profile that stenosis, and we just wanted to go over an example of that with you in this set of 4 slides. You can see here on the top left, we are what I call in the pre-stenotic area, where we're evaluating the common carotid artery proximal to a suspected lesion right here at the origin of the internal carotid artery with acquisition of this spectral waveform. We would then move on through that stenosis, eliciting the highest velocity within that lesion. And the way that's done is by moving that sample volume back and forth throughout the color flow image, up and down within the vessel, to find the highest velocity within that lesion, keeping in mind that this is the velocity that should be reported to your interpreting physician. The highest velocity is the one that will be used in the estimation of the stenosis range. The sample volume is then moved beyond the lesion into the area of just immediately beyond the tightest part of that stenosis, where you should see a spectral waveform that looks something like this. This is what we refer to as post-stenotic turbulence, and you really should be seeing post-stenotic turbulence in any patient in whom you suspect a hemodynamically significant stenosis. The absence of this type of a signal beyond a hemodynamically significant stenosis when it's suspected really should prompt you to go back and really evaluate that area. Post-stenotic turbulence will almost always be present when you're looking at a patient with a hemodynamically significant stenosis. And then we see here that we've moved the sample volume well beyond that area of stenosis to get a look at that distal internal carotid artery waveform. Sometimes the degree of spectral broadening and occasionally the presence of a tardus parvis waveform way out here beyond the stenosis will give you an idea about the severity of that lesion. So this is what we refer to as profiling the stenosis, to elicit the highest velocity within the stenosis and to confirm the presence of a true stenosis by demonstrating the presence of post-stenotic turbulence. In terms of the examination itself, we like to test our patients on the examination table with the patient supine. As you can see in these images, it's okay to examine the patient by standing up and facing the patient, or you can sit at the patient's head. I think either one is okay, and I think you should do whatever you feel most comfortable doing. Of course, access is important. You need to remove any tight sweaters or chains that don't allow you access of the carotid artery system from the level of the clavicle here at the base of the neck all the way up to the angle of the mandible. You really need to have access to do this study well. So if there's any tight sweaters or turtlenecks, we remove those. And of course, you want to be doing both sides. We always start the examination by evaluating the right side first. So we'll turn the head slightly away from the right toward the patient's left, and we like to have the chin pointed up. A little bit of a technical tip here in patients with very short necks or very high bifurcations. You can sometimes put a little pillow underneath the shoulders, and that will hyperextend the neck to give you more access to the distal internal carotid artery. Now, we start off every examination with what I like to refer to as a transverse sweep. And this is just a short axis sweep that starts at the base of the neck and then works its way up to the bifurcation of the carotid artery vessels. And we do this because it gives us a nice preview of the extracranial system. It allows us to get an idea about the location of the bifurcation. In some patients, it will help you differentiate the internal from the external carotid artery. It will, if you put your color on, it will very quickly allow you to assess for patency of the common carotid artery branches by the presence of color within those vessels. And it also allows us an opportunity to note any extracarotid pathology, particularly the thyroid. And in patients with plaque, it allows you to determine the location as well as the extent of plaque burden within the carotid arteries. Every examination, of course, starts out with an evaluation of the most proximal common carotid artery. Now on the right, because of the anatomy and because of the presence of an innominate or brachiocephalic artery, you can almost always see or image the origin of the common carotid artery. And when you can, I think it's appropriate to go down there and look. So we image the proximal common carotid artery and we look at the flow waveforms. This is used to determine for the presence of proximal disease. Keep in mind, especially in patients with very focal and moderate levels of disease, who have symptoms referable perhaps to a stenosis at that region, if you're too far downstream, you may in fact miss that lesion because the flow waveforms tend to normalize the further you move away from a stenosis. So if you can get very proximal in these patients, you're likely not to miss those lesions. Disturbed flow is not uncommon because of the proximity to the heart in these patients. And of course, it may be more prominent on the right because you can get much closer to the origin on the right. I think the important thing in these patients is to look for side-to-side asymmetry in terms of both the velocity, the waveform, and the size. And while I'm on that topic, keep in mind that within the carotid system, asymmetry is very important. There really should not be much difference between the right and the left carotid arteries, although you may know the difference when you're looking at the vertebral arteries. So, evaluation of the common carotid artery again starts out at the origin. Another reminder is that we should be evaluating the whole length of the carotid artery system using all the tools in your toolbox, and we always use color. In the old days, before we had color, we had to take that sample volume and step it through and move that sample volume up and down and back and forth within the carotid artery system. However, again, one of the advantages of color flow imaging is that it allows you to see a wide field of view. And what we do is we allow the color flow image to tell us where we need to stop within those areas of those predetermined sites for evaluation. Any area that looks suspicious by the color flow image really should be evaluated by spectral Doppler. In the absence of any evidence of a flow disturbing lesion or any other pathology within the carotid system, of course, we would stop at those predetermined sites to evaluate and to acquire velocities. But our next stop within the carotid artery system then would be the mid-common carotid artery, somewhere that's relatively low in the mid-neck, in an area of the vessel where it's straight and where it's disease-free. And this is an important part of the evaluation, especially if you're using an internal carotid to common carotid artery ratio. The literature states that velocity should be acquired somewhere 2 to 3 centimeters proximal to the carotid bifurcation, again in an area where the vessel is straight and where it's disease-free. One of the other reasons to look at this part of the common carotid artery is to compare the end diastolic flow velocity to the contralateral side, keeping in mind that asymmetry should be noted and interpreted appropriately. For instance, the absence of diastolic flow ipsilaterally really should clue you into the possibility that there may be something going on distally. On the other hand, if you're looking at a parvis tardis waveform where you have decreased velocities on one side versus the other, you have to start thinking about the possibility of more proximal disease. If you note any areas of flow disturbance or plaque within the carotid artery system, anomalous waveforms, that really does require an explanation. And if you do see flow disturbance in the absence of having been able to detect a high velocity proximal to that, you really need to go back so you can explain that finding. In the absence of being able to explain that finding, you really need to qualify your report accordingly. The next stop then would be the distal common carotid artery, and what we like to refer to as the flow divider or the bifurcation. And I know some people may call this the bulb, but keep in mind that the bulb could have involved any portion of the common carotid artery system, including the internal and the external carotid arteries, or it may not involve any portion of the carotid system at all. Now, the bifurcation may be an area that is dilated and bulbous, and it is an area where you may develop disease, and this is the reason why we like to stop here and acquire a flow velocity, keeping in mind that the highest velocity within a stenosis, if the disease does involve the bifurcation and the internal, may in fact be at the level of the bifurcation, and you wouldn't want to miss that by reporting out a lower velocity acquired within the internal carotid artery. The waveforms at this level may be a little bit different than those that you've acquired more proximally in terms of the diastolic flow component, and that's okay. That's something that we expect and something we don't get too excited about. Again, because the disease may be a little bit more severe at the bifurcation, if the velocity obtained at the bifurcation is higher than that obtained in the internal carotid artery, then that would be the velocity that you use in your ICA to CCA ratio. It's also important if you see plaque and disease in this area to evaluate the vessel from multiple views when you're attempting to elicit the highest velocity within that lesion. Now, once we've moved beyond the bifurcation, it's now very important to be able to differentiate the internal from the external carotid arteries, and the primary way to do that is by evaluation of the waveforms. Keep in mind that the external carotid artery will have less diastolic flow than the internal carotid artery in normal cases. Sometimes tapping on the superficial temporal artery will help in that it causes oscillations within the external carotid artery. However, keep in mind that if you do elicit these oscillations within the external, you really should go back to the internal and do some tapping there to make sure that you're not seeing oscillation within the internal as well. If you're seeing oscillations in both vessels, then this parameter will not be useful. In fact, tapping of the superficial temporal artery really is the least useful of all the parameters in terms of differentiating the internal from the external carotid arteries. The external carotid artery does have extracranial branches. This is something that you will not see within the internal carotid artery. So the presence of branches when you're evaluating these patients will help in terms of identifying the ECA versus the ICA. However, keep in mind one of the pitfalls is that if you do not see branches, this does not necessarily mean that you're looking at the internal carotid artery. It only means that you're not seeing branches. So it's the presence of branches that's helpful when differentiating the ICA from the ECA. The internal carotid artery is usually larger and anatomically is positioned posterior and lateral to the external carotid artery. And typically in most cases when there is a bulb, it will be associated with the origin of the internal carotid artery. And here we have just a few images to show you how I evaluate these patients. In this case here on your top left, we'll note two vessels beyond the bifurcation. Here's one on the near field and one here in the far field. And we can see here in this vessel, which is a little bit further away from the transducer, we see several branches. This, of course, would be the external carotid artery. We can see also that at the origin of the internal carotid artery, this vessel is bulbous. Again, some evidence that this would be the internal. But really the primary way to tell the difference is by looking at the waveform, so that when we look at this vessel here, the one located more anteriorly, we see a waveform that yields continuous forward flow throughout diastole, much more diastolic flow than its counterpart, the external carotid artery, which has a sharper peak, much less diastolic flow. And here in this 2D image, without color, we can see the presence of several branches. All of this confirming that in fact we are looking at the internal carotid artery in this vessel and the external carotid artery here in the far field. Now, once you've determined which vessels you're looking at, we would then carry the examination out through the proximal, mid, and distal portions of the internal carotid artery. And in our facility, we have strict definitions about the determining the portions of the internal carotid artery. The proximal ICA, of course, is that typically that dilated area just beyond the carotid bifurcation, usually a 1 to 2 centimeter segment distal to that level, and this is the area where disease is most likely to develop. Keep in mind, this is where most of the action will happen, here at the origin of the internal, sometimes the carotid bifurcation. All of the criteria that's out there and used for estimation of carotid stenosis has been validated for disease that involves the internal carotid artery at its origin. It's not applicable to the external carotid artery. It's not applicable to the common carotid artery or to the distal ICA. Although it is important to look at these vessels, the stenosis criteria really should be applied only to the origin of the internal carotid artery and sometimes the carotid bifurcation. The mid-internal carotid artery, of course, the examination is carried on throughout the whole portion of the extracranial carotid, but we define the mid portion of the internal carotid artery as that area about 2 cms beyond the bifurcation. Typically beyond that dilated area, the vessel walls tend to be straight and tend to be a little bit more normal diameter. In some cases, disease may extend out into this area, but in my experience, it's unusual to find a patient who has disease that involves only the mid and distal portions of the internal carotid artery, in the absence of disease in other areas of the extracranial carotid artery vasculature. And this is important because you don't want to make the mistake of diagnosing a high velocity as an atherosclerotic plaque in the absence of plaque in other places. Now, you can absolutely have pathologies out in this area, typically not referable to atherosclerosis, especially again when there's no disease anywhere else. But for instance, if a patient comes in after a car accident and maybe has a seatbelt injury or has some trauma to the neck where you're eliciting a focally elevated velocity in this area, it's more likely to be a traumatic injury such as a dissection or an intimal flap rather than an atherosclerotic lesion. And this does make a difference in terms of treatment for that patient. The examination is then carried out through the distal internal carotid artery, and that is that segment that's at least 3 centimeters beyond the carotid bifurcation. Again, this is an area where atherosclerotic disease is not usually seen, although you can encounter other pathologies, most commonly things like fibromuscular dysplasia. It's not uncommon to see loops such as you see here, or kinks, or coils. Occasionally you see these S-shaped tortuosities, and when you see these tortuosities, kinks, and coils, they can all result in difficult angles for evaluation, and therefore artificially or artifactually elevated velocities. And typically what I would do in the evaluation of these patients when trying to elicit flow disturbance, if I suspect that there's pathology, is I'll use a 0-degree angle and just step that sample volume through the whole portion of this part of the internal carotid artery to look for flow disturbances, potentially the presence of post-stenotic turbulence. But keep in mind, again, it's unlikely that a flow disturbance in this area will be referable to an atherosclerotic lesion, and therefore your interpretation needs to state that accordingly. We would then complete the extracranial carotid examination with an evaluation of the external carotid artery, and that flow velocity signal really is obtained at or near the origin. Primarily, it's used to distinguish that vessel, the ECA, from the internal carotid artery, and we do that primarily, again, based on the shape and morphology of the waveform, which should differ from the internal carotid artery, as I've already described. The examination then is taken out to the vertebral artery, and the best way to identify this vessel is really by straightening the patient's head out just a little bit, using a very anterior approach to identify the common carotid artery, and then angling that transducer laterally, where you'll usually be able to identify an image such as this one, where we can see the vertebral artery body, the spinal process, and then the vertebral artery again. And this is a classic image for the vertebral artery. We would probably evaluate the vertebral artery somewhere in this area using the appropriate Doppler angle to assess for the direction of blood flow, keeping in mind that flow should always be moving from the heart out to the brain, in this image from your right to your left. So we would set the color scales and the color direction appropriately and look for flow either moving towards or away from the transducer. Now, if you suspect a stenosis or some atherosclerotic process to be going on in the vertebral artery, which is not common but can happen, typically that will happen at the vertebral artery origin. And the best way to define that and identify that is first by finding the vertebral artery in the mid-neck and using the color flow image to allow you to work backwards to its origin and then evaluate the vertebral artery origin for the presence of stenosis. This is a typical vertebral artery waveform. It will somewhat mimic that or be a combination really of the common and the internal carotid arteries. It should be low resistance because it feeds the brain directly through the basilar artery where both vertebrals come together. So really you should be seeing a sharp upstroke, which again you should see in all vessels within the carotid system in the absence of significant proximal disease, but lots of diastolic flow. Here in this case we see a series of various waveforms, and it won't be uncommon to see something like this here where you, on your top right. It's a waveform that we refer to as a systolic hesitation, where the peak, in fact, of the waveform is displayed below the baseline. And this is the type of waveform that you might see in a patient with a latent steal. These patients who present with subclavian steal syndrome, which would be an indication to look at the subclavian arteries. And really, this is a phenomenon that occurs in patients who present with proximal subclavian artery stenosis, proximal to the origin of the vertebral artery, so that what happens is as the heart pumps and it pumps out the blood, the flow will traverse up the contralateral vertebral artery, around the horn, and then move in a retrograde fashion down the ipsilateral vertebral artery to perfuse the ipsilateral upper extremity in the presence of this subclavian artery stenosis, which is no longer able to perfuse the arm. When you see these patients, they often will come in with asymmetric blood pressures or symptoms referable to the posterior circulation. The peak incidence is in patients who are between the ages of 40 and 60 years. Males outnumber females 2 or 3 to 1, and it can also be seen in patients younger than 30 years of age, in patients who have Takayasu's disease or giant cell arteritis. Now, these patients can come in and demonstrate various vertebral artery flow pattern changes, usually consistent with the degree of disease within the subclavian artery, and in fact may have a normal waveform at rest or can yield systolic hesitation. They can sometimes present with an alternating waveform or may just come in with complete reversal when the stenosis within the subclavian is very severe. Now, in patients in whom you suspect a subclavian steal syndrome who present with normal waveforms, we can do post-occlusive reactive hyperemia testing, and this is very simply done by placing a blood pressure cuff on the ipsilateral arm and inflating that cuff to a suprasystolic pressure while monitoring the flow changes within the vertebral artery. After 3 minutes or so, that cuff can be deflated. Of course, we're creating a hyperemic response here in the ipsilateral upper extremity, and if that subclavian stenosis is significant, the flow within the vertebral artery will reverse. Some patients, if they can, you can allow them to exercise while evaluating the changes in the vertebral artery, and again, if the subclavian artery stenosis is hemodynamically significant, you really should see some changes within the vertebral artery. Again, these are some of the symptoms associated with vertebral artery disease. Posterior circulation symptoms include dizziness, drop attacks, lightheadedness, visual disturbances, and these are a few of the other symptoms associated with patients with this type of disease. When they present, you really should be evaluating the subclavian artery. Now, of course, a normal subclavian artery will yield tri- or biphasic flow depending on the vasomotor tone. Typically high resistance in nature. All vessels, again, should have a sharp upstroke and a systolic peak. When disease starts to set in, you'll see an increased velocity and turbulence, with increasing turbulence with greater disease severity. Often these patients in very severe forms of the disease will present with delayed systolic upstrokes and rounded peak velocities. And then the end-stage manifestation in patients with occlusion would be this very blunted, sometimes tardis parvis waveform. Now, that's the evaluation of the patient with carotid artery disease in terms of the use of carotid duplex ultrasound. If you want more details about these professional performance guidelines, I would refer you to SVU's website. That's www.svunet.org, and very soon we'll have some DVDs that will also go over the technical performance of these examinations. Thank you very much. I wish you good luck and happy scanning.